I've only been asked to chair a meeting at the end, because I felt at this point what else could go wrong. There was a huge risk about putting me on at the beginning. These are our sponsors. It's the renal cancer panel. Do you want to introduce yourselves? Perhaps, Tony, you'd like to start, and we're coming this direction here. My name's Tom Poulter.
Tony Schwery, Boston.
Yes, you are.
Monty Powell from Los Angeles.
Correct.
Brian Reedy, Nashville.
100%.
And John from Dallas.
Also correct.
You get 2 points.
Yeah. We're going to talk about something which is really relevant for two reasons. Firstly, we've got a series of studies that have come out relatively recently in this important space, the most relevant of which I think is Contact-3, but there are other trials too. And then more recently, we had this belzutifan discussion, which Laurence presented at ESMO recently. And we're going to try and get some feel about what we should be doing here and how we're going to sequence. I got the introductions all wrong at the wrong time, and I apologize. So why don't we start with this? Tony, I think you were first author on this. It was a negative trial, and it was published in The Lancet. It was one of the most, in fact, I could have led this trial easily, because it's one of the most negative trials I've ever seen.
Yeah.
And I was surprised. Yeah. I was surprised. I was surprised that I wasn't asked to lead this very negative trial. Tony, could you explain not only why I wasn't asked to lead it, but perhaps more importantly, why it was such a negative study and what we've learned from that?
Yeah, when this Contact-3 started, we wanted to involve you, but at that time you didn't have the track record that you have now. So we thought that by excluding you, the trial could be positive.
Right. Well, thank you for clearing that up. I didn't know that at the time. It'd be nice to.
We're superstitious. We believe in black magic, many things. Anyhow, I am not, honestly, very, very surprised, because we get a lot of second opinion where IO, PD-1, PD-L1 were re-challenged in patient. We do have a preclinical rationale that either way, it could be or not be positive. Our retrospective studies, have been, also all over the place. And we thought that, once for all, let's address that question in a prospective fashion. It's not just negative. Brian alluded to that a few panels ago. The toxicity is higher. I mean, 2 drugs versus 1. Despite being manageable, the toxicities were really higher with more immune-related AEs, as you can imagine. I think it puts the whole PD-1, PD-L1 re-challenge into questions. But these are patients whose tumor experienced disease progression, not toxicity. Actually, the reason why we have less immune-related AEs than cabo-atezo frontline that Monty reported is because these patients, if they had bad immune-related AEs, they wouldn't be eligible. So it picks really, and even with that, they did have some. So totally negative. I think it puts a lot of, these concepts. This is why it's in a general, medical journal like The Lancet published. The last thing I want to add is that, and you come to that, there's another study, finish accrual. And the surprise, Monty and I led that study, the big surprise is that when we looked at other solid tumor where PD-1 and PD-L1 inhibitors are standard and sometimes before kidney cancer, there was not one study with similar-ish design. Not one randomized phase 3.
In the wider community. Monty, I'm going to come to this in a minute. Maybe, Brian, you can answer that. Are there any patients who you would challenge with immune checkpoint inhibition in this setting? It's a negative trial. I think you were the senior author on it. We chatted about it on a number of occasions. Is this just killed the whole space all over? Or in advanced disease, I'm not going to talk about the adjuvant setting, I'm going to come to that in a second. In advanced disease, are there any patients who you'd re-challenge?
I think the onus is on us right now to prove that IO in the refractory space works. I can't think of an example off the top of my head where I would consider, 5th, 6th, 7th line IO therapy, particularly because, as he showed in that previous slide there, we really are probably doing some harm by offering these patients secondary and tertiary IO.
Monty, what about Ipi-Nivo up front, 4 cycles, great response, CR, stop therapy because the patient, that Dave McDermott treatment-free survival.
Yeah.
And of course it doesn't. The cancer bounces back. Everything's gone wrong. What about that? So great response, treatment-free survival, and then would you want to re-challenge with Ipi-Nivo a second time, or would you challenge with Axi-Pembro? How would you? Because I've done that.
Yeah. I mean, that's an awfully short duration of therapy, just 4 or 5 cycles.
But spectacular response.
Yeah.
You would re-challenge that patient, wouldn't you?
Yeah, I have to tell you that, if that response sort of resurfaces, if that response diminishes, I would say maybe after 3, 4, 5 years, then maybe I would give some thought to IO re-challenge there. But having said that, if it's sort of a short-term recurrence, I think the IO should still be taking effect, so I'd probably transition to TKI alone.
Brian, talk to me. This is one of our slides that one of our polls, and we'd like to thank all of the people who are involved in those polls, and that's something have we done that yet? We thank the social committee.
Pleasure.
And Shilpa and Neeraj.
Shilpa and Neeraj, but all of these incredible polls. Is this correct? Half the people felt it's just Cabo had high activity.
Yeah, I think there's a lot of issues to this. So, clearly there was little activity, right? Or a little differential activity. I agree with what Monty said. I think the onus is on proving that it works when there's increased toxicity, especially toxic deaths, right? So the onus is on us that there is benefit and acceptable risk, right? And I don't think we've shown that yet. To your other question about, is there anybody you'd consider re-challenge? Contact 03, I think, just had 1 patient on each arm with adjuvant Pembro, right? I assume Tanivo 2 will be different. But to the point about, well, what if, many months to years, how long, I think we have a slide on that, what's the gap where you'd say, well, so much time has passed that I think you can re-challenge. I think that exists, but I don't know what it is.
Brian, who did we do that great podcast with? We did one with Samra, we did a second one, and I can't remember, it's awful, I should, but what they talked about in their, I think it was Nature Medicine paper, was that essentially tumours are pre-wired to respond to immune therapy, and that although immune therapy is associated with the immune infiltrate, that immune infiltrate is not an educated immune infiltrate, and essentially you're wired to respond or not respond, and that those patients that respond are going to respond to first-line therapy, and why would more immune therapy...
Well, you've removed all the great immune responders here, right? They didn't end up on the trial because they're still either on therapy or in David's treatment-free zone, right? So you've enriched for this angiogenic phenotype, which might be one reason why the Cabo arm did really surprisingly well, right? That median PFS, that's almost a frontline PFS from the old TKI days, right? So yeah, it's expected that both arms which have an angiogenesis inhibitor, the results would look good and similar.
Tony, you were vaguely involved in the cabozantinib program.
Very, from distance.
Do you think that cabozantinib performed particularly well? Was this surprising? There was a cantata trial. I'd like you to talk a little bit about that. And maybe your original cabozantinib versus everolimus study. And what I'd like you to think about maybe is the fact you've previously had immune therapy, immune checkpoint inhibition. Immune checkpoint inhibition has a long half-life. It re-educates, and it's supposed to have long-term effects. Are we adding cabozantinib on top of immune therapy? And the reason this failed was it was sort of cabo-nivo, and the nivo continues, and then a tezo-cabo-nivo, because you've always got the immune therapy there, and you don't need more immune therapy. What I'm saying is that, essentially, you've got immune therapy on board. It's always there. It has long-term effects. You don't need to get it for years and years. And actually, this is...
Yeah, you are correct. I think the last therapy here needed to be immunotherapy, so this could have been a study of cabo-atezo versus cabo plus IO. Nevertheless, I would say the 40% response rate with cabo-atezo and cabo is not just investigator assessed, but it's center reviewed, 40, 40, 40, 40, 40. So 4 40s, so it's real. Normally, we had anywhere between 17 to 32% with cabo activity in general in the refractory setting. So it's not completely far off. The one thing I want to add, going back to Brian, patients did not have benefit whether their prior response to the regimen, the prior regimen, IO containing, was a response, SD or PD. There was a trend in patients who experienced prior response, like you continue, so these are acquired resistance, but still it was not significant. So hopefully this study will shed more lights.
What do you think of this trial? I mean, I'm not involved in this study, and so it's likely to be positive. Do you agree with that hypothesis? And do you think, is this study gonna? Do you think number one is going to be positive? Is the design good? Is the design good? Is it going to be positive? And what do you think about the tivozanib dose?
Yeah, so I mean, we have seen some early data of tivozanib with nivolumab combination. And so I like the design. We have to see the components, right, and see what it shows. I do think, tivozanib as a control cohort may not be as hard to beat as cabozantinib as a control cohort, and so potentially we'll see a positive trial.
Do you think tivozanib is better than belzutifan?
It's different.
Okay, so right.
I don't think we've seen the
Which would you prefer to go for? You had a choice, desert island drug, VEGF refractory disease. You can only take one of the two with you. You're on the boat, you're leaving in 3 seconds. Yeah, you've got to grab one parcel or the other. Which one do you take? Tivozanib or belzutifan?
I'll take tivozanib for now.
Okay. So let's just talk about this study more globally. Does anyone want to have... So there are some subtle differences in the pre-treatment piece. Monty, I think you alluded to that yesterday. Do you want to just talk about some of those subtle differences in that patients don't need to have progressed on the most recent immune therapy? Is that correct?
I think that's one of the key differences too. In terms of study design, the other big permutation here is that we're using a lower dose of tivozanib on the combination arm. Funny enough, Tony, you remember this. This is something we were actually discussing with, Genentech up front. We had a lot of back and forth. Do we go with Cabo 40 Atezo versus Cabo 60? I'm so glad we ended up with our final design, right? Because it's truly a pure comparison of A versus A plus B that you see in Contact 3. Here, the waters are a bit muddied. I'm actually afraid that if this is a negative study, people might use it to justify using a lower dose of TKI with IO versus full dose TKI. That's one potential risk that we run.
Let's look at a PFS and OS hazard ratio. Tian, you're going to go first. What are you, PFS, OS?
PFS 0.75.
Wow.
Positive PFS and OS.
We're hypothesizing it's
Okay.
positive.
Yeah, I'm supposed to be unbiased. I agree. I'm supposed to. Okay. Yeah. Obviously, I've got a feeling what I think. What about OS? Tian, what about OS?
Oh, I don't know if it'll reach OS. 0.85.
Brian?
1.0, 1.0.
Monty?
Sorry.
Yeah, I'm going to say 0.95 and 0.95.
And Tony?
I think here the fact that you're not involved with this study will make it positive.
Oh.
So it's a 0.65 and 0.85.
I'm 0.1. I'm 1.1 and 1.1.
Wow.
Okay, well,
Yeah.
let's
Why
see.
would it be worse?
I think if you mess with VEGF TKI dose, it comes back to bite you.
I think we heard that this is a lower dose of Tivo,
Yeah.
and maybe the win will be for the single agent Tivo. We heard it before. Who knows?
And this comes back to the cabozantinib issue. We've kind of discussed this. I think that cabozantinib is performing well here.
Can I ask a question just to go back one?
Yes.
Tian, I'll ask you. So when I made this poll, it was like the results for Tivo mono are either less than Cabo, Cabo-like, or more than Cabo, right? Those are sort of those three categories. So let's say the PFS is 11.5 months for Tivo monotherapy, right? Would it influence your use of that drug?
I think so. I've seen some people have good durable responses in the refractory setting to tivozanib. So to back up my desert island question, I think if you take large populations, and we will get into the belzutifan data, but if we take large populations, tivozanib, we have now good data, and we've seen some good responses. And so I think it's specific patients who might benefit from bel in the refractory setting. And so Can we still, sequence them? Absolutely. But if I had to pick right this moment of all comers, maybe TiVo. To your point of could we see a little bit over 11 months? I think they're all good drugs, right? And we want to be able to use more options for patients in the refractory setting and have them be able to sequentially improve progression-free survival and thereby overall survival.
If I may, Tom, I think this is going to be an incredibly informative study regardless of my practice. What I do a lot now, Brian, you're going to be shocked to hear this. I start a lot of patients on Cabo-Nivo up front, first line, yeah. So, for a second line, I find myself sort of a little struggling between choices of Len-Ev or tivozanib. I'm using a lot of tivozanib, actually, second line beyond Cabo-Nivo. So, that PFS estimate there is really going to help sort of substantiate my choice.
Monty, are you using len-everolimus for emotional reasons or clinical? How have you come to that conclusion? Where does that come from?
Yeah. There's a certain component of emotion in every decision I make, I think. But what I will say is that, if I see that patient who really needs a rapid response, if they're symptomatic, from their disease and really struggling, I would probably side with Len-Ev, provided, they're robust enough to tolerate the regimen.
Do you think len-everolimus is more active than cabozantinib?
No, I'm using Cabo up front.
And do you think Len-Ev is more active than axitinib?
Do I think Len-Ev is more? I do, yes.
On a 50-patient randomized phase 2 with no clear OS and all the bits and pieces, the Len arm performing pretty well by itself.
Yeah.
You're totally sucked in on that 50-patient trial.
Not only that, but we ran that
You're
dose
doubling down
finding
on
study,
this.
right? So we ran that dose finding of Len-18 versus Len-14 with 300 patients.
This is the emotional bit, is that right?
That's the emotional bit.
Yes.
So I'm very passionate about this, right?
I knew
It's a
you would
study
be.
that I
I knew
ran,
this is
and
why I pushed you a
we
little
really
bit.
struggled to get it published. Nobody would take it. And we
I'm not
finally
surprised. I think I reviewed it a few times.
That's why it didn't get anywhere.
And finally, I put Tom on the do not review list, and got in. But great PFS in that study that really mirrored what we saw in the phase 2. So again, 300 patients there in total getting Len, and I think the PFS and response rates were reasonably consistent with what we saw in the randomized phase 2.
All the other combinations of everolimus haven't worked out that well. We've done a lot of trials, big studies, bigger than these 50-patient trials, where we've combined everolimus with bevacizumab and other drugs, and they've always been negative. And now we have this 50-patient trial with len-everolimus, and we really want to, are we, and of course, I should say, the CLEAR trial, the hazard ratio was 1.1 PFS, so the OS was worse than, or not worse, but it was above 1 compared to sunitinib. And so, do you think that, with that big CLEAR study, do you really are you still len-everolimus? We've tried this so many times. There was one small study, no OS, and we kind of go on the positive trial and we ignore all the negative data. Is that what we've done with len-everolimus?
I mean, I do deprioritize everolimus in the combination. If my patient's suffering from any mild degree of stomatitis, I'll just ditch it. I'm really trying to prioritize, sort of dose intensity with the lenvatinib, which in and of itself is very challenging.
Tian, the boat has actually come back to shore. And you've got the tivozanib with you, and you're grabbing it. And the boat, the guy who's docking said, "I've made a terrible mistake. It wasn't belzutifan I was supposed to give you. I was going to give you the option of len-everolimus. Are you taking len-everolimus to desert island with you, or are you going to stick with your tivozanib?"
And the same patient.
Exactly the same. Yeah,
They've had Cabo-Nivo.
Yes, the Cabo-Nivo patient.
I think
he says the data's not that great. That's what he says to you, because he's he says they've got a 50-patient randomized phase 2. You've got a CLEAR trial. You still,
well,
you'd quite like to, wouldn't you?
I like lenvatinib pembro in the post IO setting.
Len-pembro. We're going to come to that in a second, but we're talking len-everolimus right now.
Len-everolimus, I think, has a lot of toxicities. I think the reason, if I may, that I hear from Monty is that the everolimus component may not actually contribute a lot, and that's why you're backing off of the everolimus quickly. I think it is a little broader in scope, so if I'm looking at a second-line patient, I would take Len with me.
Which 3 drugs, Brian, of the 3, you're now been off, unfortunately, fortunately, because you're going to have it with Tian, but you're on the same boat, and now you've got tivozanib, you've got belzutifan, or len-everolimus. Which of the 3 do you take?
Yeah, I guess about Len-Ev, I would say, we have to remember, we're not curing anybody in this setting, right? These are not curative regimens, so toxicity matters a lot. I think Len-Ev is really toxic, right? So I don't use it much. And I also think it's a little bit unfair that we have randomized phase 3 data compared to randomized phase 2 data, right? So
Yeah.
if you never do the phase 3, then you never have that decrease in data, right? Belzutifan saw it, right? PFS and refractory, it's 11 months, and now it's 5.6. So it's going to come down in a phase 3, but if you never do it, then you never see it. So it stands on its own. So I wouldn't choose that simply because of toxicity, not because it's not active, right? But more based on toxicity. And I'll dodge the other question until we talk about belzutifan. I think there's just different patients you'd use them in.
So you're taking tivozanib on the boat?
I'm taking both tivozanib and belzutifan on the boat.
Okay, we'll come back to that. I mean, you're not allowed on the boat. You're not allowed on the boat. You're still on the shore. Okay, so
That's fine too.
Who was the take on the Len-Pembro data? I mean, who would like to take that on? Monty, you were involved in the, is it your name on it?
No, I think that's Joe Lee's study.
Joe.
But, yeah, but I have to tell you, I mean, I think now, again, I'll make the same sort of suggestion. Fantastic data, but single-arm study. Let's see some randomized data here. Right? I mean, I think that now that, Tony and I have rounded out Contact 3, now that T-Nivo 2 is pending, unless we see some suggestion that there's a benefit with maintenance of IO, I'm sort of sticking with my guns and saying no IO in the
So
refractory
can I
setting.
get us all to agree on one thing? That the Len-Pen data, we should not be giving Len-Pen in any situation in refractory disease, or generally speaking in refractory disease, because there's no evidence that Pembro adds anything at
Right.
the moment. Are we all agree
I
on
agree.
that?
I'm with that, yeah.
Okay, so we're really not into sequencing immune therapy. I agree as well, for what it's worth. Okay.
Grim. Oh, sorry, yeah.
Who would like to take this slide on, Tony? I'm going to point it to you.
Yeah.
So these studies, and Brian, I think the furthest study is yours. That's a real-world data of Ipi-Nivo re-challenge. I guess the question that one's asking is, what is the addition of ipilimumab in the refractory setting? At the moment, if you want to get CTLA-4, you have to have it up front. One of the arguments for having Ipi-Nivo at the beginning is you get one chance to get Ipi at the beginning. And if you don't do it now, you're never going to get it. And some people believe Ipi has a role to play. We're going to chat a little bit about that next time. It's likely to get quite heated. But do you feel that there's any role for the addition of ipilimumab in any patients once you've been through first-line therapy? And if so, whom are those patients?
So these are different studies. The Titan RCC is totally different. It's similar to HCRN and to Omnivore led by Raina McKay. The fraction and the salvage Ipi-Nivo, the fraction is a BMS study with our group. The salvage Nivo Ipi is Brian's group at that time in Cleveland. So they're different. Let me just explain. So the Titan RCC-like studies is where you can see if you can get away with less by doing, less. So you start by Nivo. If you get a response, great. Those 20% of patients, you continue. Certainly less toxicity with one IO than two. If you don't, you add Ipi. This has not worked. It only works in mice. That's why I keep telling people that's like, you have a DFS, you can always do sequential studies. Sequence study, risk adaptive studies are near impossible to do in practice. And I think the only relative success we're going to see, relative again, is with pedigree. But these didn't work. So one is that the response rate of 13% were less than 1%. The overall response rate of 42% with Nivo Ipi up front from Checkmate 214 is around 20-25%. And most important, the attrition rate in these studies that are smaller, where the oncologist and expert involve people that do kidney cancer, the attrition rate is between 50 to 60%. So that's why I don't practice the Titan RCC. What I practice from time to time is the number 2 and 3, fraction and salvage Nivo Ipi, where I give Nivo Ipi sometimes in patients whose tumor progress on prior PD-1 inhibitor, 3rd, 4th, 5th line. And the reason is the 17%, 10 to 20% response rate, usually durable. But again, Tom, is this due to Nivo Ipi or to Ipi? We don't know. We're not going to have the trial that does that. But I do that, especially in sarcomatoid, especially when I'm running out of option. And we saw 17% response rate in those 52 patient in fraction. And Brian has similar experience from his retrospective study.
Tian, tell me about Pedigree. It's a study that you're leading. It's a big study. Everyone's excited about it. What's the story?
So it's adaptive in the frontline setting for intermediate poor risk metastatic kidney cancer. And after the first 3 months on ipi/nivo, patients are randomized based on their radiographic response. So everybody with CRs get nivo alone, everybody with progressive disease get cabo, and everybody in between get randomized to nivo or nivo-cabo. So to Tony's point, it's a sequential use of ipi/nivo followed by cabo-nivo. And we're rolling right along. We're enrolling
How
really
many have you
well. 970 or so.
You've got almost 1,000 patients in an
Almost 1,000
investigator-initiated trial.
Yes, in the cooperative groups. It's
That's amazing.
a village. It takes a lot of sites and a lot of people involved.
And when are we expecting to get the results? Is it 2 or 3 years down the line?
We're thinking we'll finish enrolling probably in the next year, and then it's a 3-year overall survival endpoint, which for now, I mean, it's been enrolling for already 4.5 years, so I would be hopeful in the next couple of years.
Tian, we're going to make sure we don't send it to Tom for review, right?
And which I'd be delighted
It
to get.
sounds like he's favorable.
Yeah, and
Favor risk.
what are you expecting to see? What's the primary? Is it PFS? Is it OS?
So it's a primary endpoint is a 3-year overall survival, so landmark but event-driven overall survival endpoint. And so if we see it, then we're getting patients to live longer with that sequence of IOs.
Brian, what do you think? We did something unusual, which is Brian made these slides and I made the latter slides, and we chaired each other's sessions. So when you made this slide, it looks like it took you a long time. What were you thinking?
Something is making fun of me, doesn't it? It did take me quite a long time, Tom. And you'll notice there's no misspellings on this slide.
No, you can tell these slides.
We're going to go down the slide route.
Yeah, what exactly were you thinking?
Well, so I think we have contact. None of us, we've all agreed that there isn't sort of a routine role and we wouldn't use it. But the idea of this slide, and there's some other animation that'll come in, is there any role, right? So there you go. The first, go back. So the first one was, well, is anybody using ipi/nivo salvage, right? And I agree with Tony. It's a Hail Mary. It's a desperation in a young, healthy patient on 4th-line therapy, and you're just praying for a miracle, right? There's no question about it. And in our Cleveland retrospective series, we did have some responses. I don't remember durability, honestly. I don't remember anything being particularly durable, but
they weren't durable.
You're hoping for that miracle, yeah. So that was the idea. And then, if you just go back to the slide you were making fun of, so yeah, they're different, right? This one's adaptive, one's prospective, but they all kind of show the same thing, right? They show minimal activity of introducing ipi later in the disease and a whole lot of early PD, right? So
why isn't this a complete waste of time?
Why isn't it a complete?
Yeah, you say it's a Hail Mary. Are you just giving patients false hope by saying there's this regime, there's no evidence it works, the data's not great, but I've got no better ideas? Isn't it just better to say I've got no better ideas?
I think you could make an argument that a phase 1 trial might be better than salvage ipi/nivo.
Okay.
Yeah, I wouldn't disagree with that. And it's been a long time since I've done that.
I've had some mixed, experience. I had some responses. 17% is not, nothing. Now, if you look at fraction, half of these patients, if not more, receive PD-L1 inhibitor, because the centers that we opened, that we also had the Javelin study open. So, if they had pembrolizumab or pembrolen or pembroaxi, would you have seen with nivo-ipi the 17% response rate? I don't know.
Monty, are you re-challenging anyone? The patients who come in, they did well with ipi/nivo initially, or they got axi pembro to start with, and they come back a year later doing quite well, and suddenly there's a bit of progression. Do you have a conversation about adding in ipi? This is obviously off-label and all the bits and pieces, and they come in and say, look, I've never had this frontline regime associated with long durable remissions. I want to have a go.
I do point to, sort of their data in this context. And again, this is 5th, 6th, 7th line, and all
This is not 2nd or 3rd line.
This is not 2nd or 3rd line for me.
Right.
Absolutely not. Absolutely not.
You skipped the rest of the questions.
Pardon?
You skipped the rest of the questions.
Oh, no, I'm going to go with the questions. So, okay, so I apologise. Brian's much more, as I said, he didn't make the slides. So, are we comfortable with PDX-based clinical trial in IO-refractory disease? Is that something which, and I think this is an important question. I'm doing a lot of studies at the moment, where we are testing the latest immune therapy in heavily pretreated patients, because that's what we've got used to doing. And I'm not seeing terrific results personally across the board without going into the detail of the trials. I'm not seeing CRs in this space. It comes back to the places, are we trashing our really good immune therapy drugs in these very, very difficult environments? And is there a better way of doing this? Who wants to start with that? Brian, why don't you
I'll
start?
start. I mean, the reason I put it on there is that, as you say, we see a lot of novel immunomodulator X, and we're going to stick it with the PD-1 inhibitor and test it in IO-refractory, whatever, in this case, kidney cancer, and it's not really been successful, right? So I'm less and less comfortable with that approach, because if the PD-1 inhibitor isn't adding anything, then it's just the immunomodulator, which is fine, but then just test that, right? I mean, so we're giving an extra drug with extra toxicity for no benefit. So, and again, like Monty said, the burden is on proving that there's benefit. So I'm more of a fan of testing those combos even in untreated patients or in IO-naive patients.
So I've got the latest great immune therapy, whatever it might be, something 40.
Interleukin 2.
IL-2.
OX40?
I've got a new drug. Monty, what's the design of my new drug? So I've got I come to you, I've said I've got this biotech company, I've got this drug, I think it's amazing. I've got $50 million that I want to invest in phase 1, phase 2. How do I make sure, I'm sure it's active and we've got data, phase 1 trial, which is kind of shows responses, not in renal cancer, but it's an immune agent. What's the trial design to prove it has activity to take to randomized phase 3 in the knowledge that we're not super keen on the IO experienced population?
And as you as a company, are you insistent on the fact that you require this PD-1 backbone for the agent to work?
I think we've showed monotherapy activity.
Okay. You show monotherapy.
So we've showed monotherapy activity. So
Yeah.
I'm happy to say that I think I can persuade people it's active, but I don't think it's active enough to beat frontline oxypembro as a monotherapy.
Yeah, I think the only way into that space these days is TKI plus minus. I think you do that this sort of phase 1 study, show that there's additivity or synergy, and then try to plop it into, a phase 2 or randomized study in the second line setting or beyond.
And I've spoken to people who've come to me and said, well, the best place to do it is in the adjuvant setting, because that's the purest and that's the cleanest. Do you think is that the place we should be doing new immune therapy trials in the adjuvant setting?
No, I think the burden of proof is initially, on activity in the metastatic setting before you jump into putting patients at risk for adjuvant.
With a new group, great immune therapy, is response still the primary endpoint, or is there a better response parameter? Is there ctDNA? Is it PFS? What is the endpoint of these new immune therapy trials that we're going to need to do? Because if we can't do it in immune-refractory disease, we're going to have to bring it into the frontline space. If we're going to bring it into the frontline space, we're going to have an endpoint. What is that endpoint?
Yeah, we've talked about this sort of ad nauseum since the introduction of PD-1 inhibitors. And I think, the conclusion of all this is that we just need to keep the goalposts stable and steady. It's still going to be PFS, response rate, et cetera. I don't envision that changing much.
TFS.
But to a biomarker-directed role, right, we need to do these in the phase 3s that have been completed in order to find the right patient populations and then test them prospectively. So until we get there as a field, we won't find those small populations where, sequencing these active agents, even active monotherapies are good, but maybe it's a small cohort of patients.
Tony, before I come to you, I'm going to go to Tien.
Rena has a
To the
question.
disease
Rena.
Right, let's go. Let's do it. Let's do it.
Thanks. So I love the question about the adjuvant. I would want to get you all's thoughts on actually neoadjuvant, because neoadjuvant provides a very unique opportunity to directly assess the in vivo effects of various drugs in a very concentrated kind of way. So could that be a platform to better understand biology, an early signal of efficacy? We've seen responses to different agents, even IO agents, neoadjuvant to surgical resection. So thoughts there as a platform for drug development.
And Raina, what endpoint would you use?
I think you could be flexible in this setting, actually, because you could think about novel immune endpoints like T-cell infiltration, other various parameters like that. We haven't defined what a pathologic response is in kidney cancer. We had a cohort of patients through a very large multi-institutional analysis of patients that were advanced metastatic that got IO therapy and then ended up getting delayed cytoreductive nephrectomy, and we actually saw significant tumor downstaging. We saw that 7 patients out of this cohort actually had no residual tumor left behind. Now, obviously, this was a selected cohort for very extreme responders, but I think what that would highlight is, could we use the neoadjuvant setting as a way to learn about disease biology and better understand some of these early drugs, similar to what's been done in I-SPY. It's different because they actually have a pathologic endpoint in breast cancer that's lacking in RCC, but thoughts?
We'll go Brian, then Tony.
I think the neoadjuvant space is a great playground for mechanistic studies and sort of learning about it. The problem from a clinical standpoint, we don't, as you say, we don't have a path CR well defined. We don't know, and we did neoadjuvant TKI studies, which were great, but I'm not sure it got us anywhere. So I think from a clinical, if we want to clinically develop drugs, we have to do it in frontline RCC. So ipi-nivo plus drug X, PD-1 plus drug X, I think you could do those studies. And I'm not saying we shouldn't do the neoadjuvant, I wouldn't use that to decide if my drug's clinically active, because I don't know what the right endpoint is.
Do you think we are in a different milieu now, today, than when we did those TKI studies 10 years ago? Because I think there is more...
We still don't know what the endpoints are.
No, I hear you, but we're in an environment where there's more enthusiasm with our surgical colleagues that are in the room and other colleagues to actually be able to do those trials in a robust way.
I think we can do them. I think we can absolutely do those studies. I don't think they're going to give us any clues for clinical development, though.
Yeah.
Because I don't know what a response is. I don't know what it means. You'll see activity for sure.
And the Prosper study set the field a bit back, at least in the mind of some folks. The one thing I want to add, what you did, and Monty, I agree with Monty when he said, look, you start developing drugs in later line and take them to adjuvant. I think it is fair, it is ethical, but there are some situations, and there are some situations where, of course, look what we did with the HIF2 inhibitor, fine, but there are some situations where drugs frontline will have more activity or even all the activity, or it's smart to introduce them. So the example is what Alliance is doing. I give a lot of kudos to Jonathan Rosenberg in this study led, I believe, by Matt Galsky Modern, where it's based on the ctDNA, your work, Tom. In case if it's positive, about, after adjuvant nivolumab here, it's very reasonable to add a drug that does have, side effects that are manageable with a LAG-3. This hasn't been investigated or approved in metastatic disease, but I think that design has equipoise, even though, what Monty said, it's not being that. And we have to think about these smart designs more and more. Can't do it in RCC, doesn't shed ctDNA so far. So far it's a bust, not for long. But I think, Jonathan, that's a great design with Alliance, by the way.
So, coming back to Reina's initial question, I do think neoadjuvant studies need to be done. Now that we do have active agents in the metastatic setting, we have particular instances, right, like IVC thrombus, large bulky tumors, where we have opportunities to partner with our surgical colleagues. So we currently have a trial open with lenvatinib and pembro for IVC thrombus. We need to look at what that does in the tumor microenvironment. We need to understand what that necrosis, 7% pathologic tumor necrosis looks like, who are set up to have those types of responses. And then, go into a randomized way into a neoadjuvant study, because we can still cure some of these patients. I firmly believe that if we use active therapies earlier in the disease course, we're set up well to cure some of these patients.
Speaking of curing patients, one of my favorite moments of this meeting so far was Reina's frustration when during the Euramigos Cup, when there was a question about 564 that Tony refused to press the button, despite being which is almost certainly why.
Let's talk about it.
Almost certainly why that team lost in the end, was because of Tony's buzzer. I'm going to call it buzzer hesitation.
By the way,
which is a syndrome.
Just for the record,
yes.
The answer was Halloween from Petros, which is a Tuesday.
Yes.
But the press release actually was Wednesday.
Right.
So you gave them 6 points, and
yeah,
the answer
there is an
no.
appeal process, and I've launched the appeal, and you're going to find out about it.
VAR?
Early next week. The appeal process is coming through, Tony. You'll be pleased to know. So, Tony, let's go on to that. We're maybe curing patients.
We were not told on Tuesday. about the press release. I didn't know that.
So what I want to know is, for those patients whose cancers progress after adjuvant pembro,
Yeah.
what is now first-line standard of care from a global perspective? And,
Well,
and I'd like to hear from all four of you, because it's going to become more and more common. I get asked this question quite a lot.
I can tell you what I do. I do cabozantinib,
Single agent.
single agent. But
All the time.
again, all the time.
3 years later,
And
relapse.
60% of the time, it works every time. So let me tell you what movie. Good. The people that left in the room are the cool ones, Tom. What I want to say is that it's all going to go back to the platinum in neoadjuvant with our friend Rob Dreiser. And this is at 6 months, 12 months. Obviously, somebody whose tumor progressed after a year and a half from adjuvant pembrolizumab, I'm going to consider them IO naive. Although this may not be correct. This is different than someone who, after, let's say, 6, 7 cycles, I'm doing their scan before the last dose, and they have significant,
So it's
progression.
cabozantinib, that's progression on treatment you're talking about. But you've also said if they progress more than a year, you'd
More
re-challenge.
than a year, I re-challenge.
Is it a year?
Like
Is a year your cutoff?
Correct.
So if it's not 11 and a half months, you don't get it. They get cabozantinib.
11 and a half.
Just wait 2 weeks and give it to them.
I wait. Actually, I write the orders. The
Yeah.
insurance take 2 weeks for clearance, and then it's a
So
year.
what is your cutoff? Is it 11 and a half months or is it 12 months?
No, it's 12 months. Day more, day less. No, we're here into science.
You're black and white with this.
I like the green color, but yes, I'm
Black
in
and
this.
white.
Yeah.
Okay, I'm happy with that. So Monty, what I want to ask you is, let's say they, the first question is progressing on therapy, would you ever add an IPI? So let's say you're on pembro and things are going badly, new lung metastasis, and they're 9 months into therapy. Would you ever switch to, what's your treatment?
No, so 9 months into therapy, identical. I'm just going to TKI in that context. I can't think of a setting where I'd use salvage IPI based on Brian's brilliant slide there, that sort of outlines scenarios. I actually think, Tom, the most confusing scenario for me that's emerged since this approval, and this has happened to me a couple of times recently, is that patient that progresses within the first 2-3 cycles, for instance, of pembro, right? Because I'm not sure at that point I've given the IO enough time to work, quote unquote, and I really don't know what to do there. So I've had a couple patients who are young, robust, and in those cases I've actually segued onto TKI IO. So this is specifically in that scenario where I've just started the adjuvant pembro and they're progressing within, say, 6 weeks. That's tricky for me. That's tough.
Tien, what I'd like to hear from you is about this late progression, and when does the VEGF TKI IO come in, or is it IPI-Nivo? So let's say there's been a year gap. I think most people would give patients a second go. Whether it's the right or wrong thing is a discussion that we need to have. I'm not convinced that any re-challenge is of any benefit. Contact 3 showed us that. And I think a lot of this is we're treating ourselves in reality.
Emotionally.
Yeah, but it's much easier to say we've got this great combination. As soon as, look, Mike Atkins, about maybe 5 years ago, he said VEGF TKI therapy is going to be a palliative treatment, immune therapy is going to cure patients, and once that's not worked, it's just going to be oral therapy. And we're segueing towards that by re-challenging patients with no evidence. Well, we've got a randomized trial showing no evidence, but we're all agreed that we're going to doing it anyway. But it may not be the right thing. This might be right. You get one good go, you cure some patients, and then. So the question I'm asking is, when are you re-challenging? Let's call it Axi-Pembro. When are you re-challenging with Axi-Pembro? Under what circumstances, or are you re-challenging with IPI-Nivo?
So you're talking people who have finished their adjuvant pembro.
Whatever you
and
want.
Now it's like 9 months, a year later.
Yeah, well, I think we've agreed that most people aren't re-challenging with immune therapy on progression on. So they've finished. How long is the gap between the finish and re-challenge with immune therapy? Tony said a year, but he didn't say which regime he's giving. What's that time limit for you, and which regime are you giving?
Yeah, I think the time, I do think the clock resets, right? T cells exhausted or activated become exhausted. They go, and we can reactivate them. And so I do agree somewhere in that 9 months to a year is when we can really harp on that window and potentially then go back into first-line metastatic treatments, not necessarily just PD-1 resistant. So I personally would give them an option. I mean, usually I'm turning to ipi/nivo, but I think if they have symptomatic disease and high tumor burden, then maybe a VEGF.
So is everyone re-challenging with ipi/nivo, or are you re-challenging with axi-pembro? Let's say they've progressed 12, 13 months after with Tony's criteria. Is it VEGF-TKI IO, or is it ipi/nivo? Tian's ipi/nivo, Brian? And let's say
you
it's
make that
intermediate.
choice like you make a frontline choice, right?
It's exactly the same choice. You're totally
We don't
ignoring
know.
the fact they've recently had an immune checkpoint inhibitor.
Right.
That's quite brave.
I mean, I haven't faced that yet, but I think if it's a year
Well, you
you're
will.
going to re-challenge, that I would have the same considerations. Because we don't know, right? There's no data.
So you go exactly the same route.
Well, I'm saying you'd have the same considerations for choosing therapy in that setting, which you're kind of saying is kind of like frontline. You're kind of
fine with
forgetting
that.
about the adjuvant
Monty,
therapy.
do you agree with that?
Yeah, more or less. I mean,
More or less.
I use Cabo-Nivo, same paradigm.
You're
that I
comfortable
use
with,
of late.
but you're comfortable with the decision about having ipi/nivo. You wouldn't get angry about it.
Yeah.
Okay, that's cool. We're going to move on to belzutifan. We've got 20 minutes, this is the belzutifan data. This is the summary of the data. Who would like to take this on? Who feels comfortable taking the belzutifan data on? Who wants the start of 10? Who wants to open the batting?
You know, I don't mind.
Fire away. That'd be nice. That'd be nice.
You know, so I was, sort of sitting front row in the audience when Laurence presented this data, and I was really, I hadn't seen any of it beforehand. I was really eager and keen on seeing what these curves would look like. I have to admit that, and I'll often do this when I see data for the first time. I'll lean on somebody who I think is smarter than me to help me reassure myself of my perspective. I was sitting right next to Bernard Escudier, and I said to him, this, doesn't necessarily blow my mind. And he sort of nodded and agreed. I mean, I had really high expectations after I saw the belzutifan data that Tony had published as monotherapy in Nature Medicine, right? So the PFS, falls short of what we saw. And, we expect this to some extent in the phase 1 experience, but there's a lot of overlap in those PFS curves, right? The median estimates for PFS are quite similar. Hazard ratio looks fine, right? OS, marginal difference there. So I have to tell you that, I would probably not change my existing treatment paradigm. You asked that question up front about TiVo versus belzutifan, because in that refractory setting, the key is if you're not, merely looking for, palliation alone, in which case you're offering nothing, you do want to get responses. You want to get responses fairly quickly. And you get that with TiVo. You don't necessarily get that with Bel. It's sort of a delayed response you see with these agents.
Quick questions. I mean, Tony, do you want to comment on that, actually? Because this is so underwhelmed with what I heard. No survival,
Yes.
Underwhelmed. Do you want to come back with that a little bit, Tony, or do you agree?
I mean, this is not the Pembro EV study you presented and you got standing ovation, but this is a positive study. This is a highly refractory population. Very few patients had one prior line. It was 2 to 3, over 80%. I would say here there's a lot of things still we don't understand why the PFS advantage start happening at month 6. What we think as a collective expert that there was a lot of censoring between center review and not center review, taking patient quickly. You see how much censoring there is with the everolimus. We were afraid everolimus doesn't cause many responses. Could that explain everything? I would think so. The median time to response, I believe, was shorter than the 6.5 months we described in the phase 1, but not explosive like TKI plus IO. I think what makes this attractive also is the quality of life. I mean, the quality of life was really superior to everolimus, which is probably slightly better than TKIs. We know that from
The response rate was 26 versus 3%.
The response was the same as in the phase 1, 20%.
Yeah, the response was impressive. Yeah. Brian, you were the co-PI of this trial, and you were quite critical of the prostate group, I thought, and it was an issue about your maturity was questioned at one point, which I've been thinking about that for some time, but it's always been difficult for me to criticize that particular area. So I was pleased that someone else spotted it as well. It did attract some criticism of the control arm of this trial as well, and one wants to be consistent. So I'll put the same questions that you put to the prostate group. You've used a control arm which has been beaten before by cabozantinib. It would have been unreasonable to use cabozantinib as a control arm in this setting in those patients who hadn't previously received it. And you chose not to do that. Cabozantinib has an overall survival advantage over everolimus, and everolimus is not a widely used drug. So just tell me a bit about how you justify that control arm in this randomized trial.
Yeah, I mean, remember this trial was designed many years ago, right? So everolimus
But Tony's study was positive by then. Tony's Cabo trial was positive at that moment.
Well,
But
there
it
was
wa-
this dinner in Munich.
I remember the dinner well. I was
No,
there.
you were there.
I was there. I was a little bit late.
to this dinner. Tom.
You came very late.
It was an
It's a
enormous.
secret dinner.
So-
Anyway, everolimus is a standard of care in the refractory setting,
Yes.
right? Certainly a global standard of care. We
Yes.
just said we all use a lot of Cabo second line. This is predominantly third and fourth
Yes.
line. So if I think you made Cabo the control arm, the study wouldn't have accrued, right?
Right.
From a practical standpoint. And remember, this is proof of principle, right? So sometimes in these first registration studies, we're looking for proof of principle. Is there activity in this setting?
Yes.
Right? And I think what would have been a shame is to compare it, say, to Cabo or some lenvatinib or something in the setting and not see activity and say, oh, this drug isn't active.
Yeah.
Does anybody believe it's not active? No, of course not. Right? We all know it's active and really well tolerated.
And
right?
the response showed that nicely. Tony, how concerning is it that there's no survival advantage and no trend towards survival? And IA2 looks quite mature. It seems unlikely to me, or do you think it's likely that we're going to get survival in the future? I mean, people say the OS is not mature and therefore we have to wait. And I'm not always sure that's the best answer to the question. Or in this case, is it not mature and we do need to wait?
I don't think we know the best answer to that question because we don't know the answer. That's so why this is the second best answer, is that we don't know. I think I'm happy that the hazard ratio is less than 1. Again, refractory population, significantly refractory. It's fine not to have OS when you have all other endpoint. Of course, the PFS, not what we thought, but we're going to have additional studies to look at the censoring, at everything, look at the data in details, and we're going to look at subsequent therapies because it's possible that you make it third, fourth line, maybe then you are at a place where they have available therapies and almost everyone gets another therapy. So we're going to look into that. I'm satisfied by the result, but of course, I would have loved to have OS.
Gian, before I come to you, I'd like you to ask about, there was a discussion about crisscrossing of the Kaplan-Meier curves. I thought it was a, now, can we just address that issue? Was there crisscrossing at the early part of the curve? Are the everolimus patients doing better initially, or is that just statistical noise in our opinion?
Well, I'll answer that with my comment is that early on we see a drop-off, right? So in the patients treated with belzutifan, there are a portion of patients who don't respond. But then there are patients who are exquisitely dependent on their HIF axis, and they do respond. And so that's why I think we're seeing this more durable PFS curve sort of leveling out and having that crisscross around month 6. And to me, I will be interested in seeing if that over populations will also contribute to an overall survival difference as more events happen. I mean, yes, there have been more than 50% of the events have already occurred in the OS curve, but I'd be interested to see if at a landmark, 30-month OS, should these curves separate out more.
And I agree from a survival standpoint, that sort of late split of the PFS curves and the time to response of Belzu, et cetera. I mean, it's possible that the OS curves could do the same late, right? We'll see, right? We don't know.
I don't think, I'm pushing back a bit on my own question if I may, but I just think that's as part of statistical noise at the beginning part of the curve. And I don't think we should get over, there will always be differences initially, and we shouldn't overinterpret that. I don't think it's doing that much initially for half the patients. I think that's a fair comment, but I don't think either drugs are, and I think there's a subgroup doing really well. And I'd love to know what that subgroup that are doing really well. That subgroup's really important. But we've got a couple more slides, if I may. The first is we've seen it in combination with a number of other drugs much earlier in the disease. Do we think that this is more impressive data than that monotherapy data? And do we think it's, in the end, does it end up as a combination in the frontline setting or the neoadjuvant setting or the adjuvant setting, or is it actually a heavily pretreated drug? A heavily pretreated setting that drug will be used in?
I don't know that it's more impressive. I mean, obviously in
I
combo
think it's more impressive.
Well, you asked me what I thought.
Okay,
Yeah.
okay, yeah.
Right? Did he ask me what I thought? So, I mean, if you see Belzu Cabo 31%, we just said Belzu's what, 23% Cabo, so it doesn't jump off the page. This is Belzu Lenva, and then, there's some frontline data which looks good, but again, single arm study, selected patients. So I think we just have to see. I think we all believe the biology would move the drug earlier, and that by definition will be in combo. But I think these are just early signals. I think it's hard to interpret.
How much is the rest of the panel encouraged by these early signals. Tony, I think you were involved in the 70, there's a 70% response at ESMO,
Yeah.
which 70% seems really high to me.
I do believe belzutifan will be more active, and I would tend to say way more active earlier. I think the results, we have the clinical result are from the VHL syndrome. I think it is totally untreated population. The responses are higher, are really high. Different disease to some degree, but VHL driven, HIF2 driven. I think here the combination in untreated patient, yes, half of them were favorable risk, but in the whole population, 70%, close to 80% in favorable risk. I think this drug will be, if I have to bet, will be really a good partner in the early setting. And I'm happy we have.
So this is not a super early, this is a pre-treated session. So the slide here is describing belzutifan and lenvatinib.
This is pre-treated, but not 3 to 4 lines.
Yeah, so this is a bit earlier, but it's not front or adjuvant. We've got frontline and adjuvant. Who thinks this trial is going to be positive? So this is pre-treated patients, belzutifan and lenvatinib versus cabozantinib. And it's positive for PFS and OS. Which one? Or both?
I think for both.
I think for both.
PFS.
Just PFS, Brian?
Maybe PFS.
Maybe PFS. So this is actually a equivocal trial. We're not convinced by this, but half the panel thinks they're going to PFS and OS, and the other half mainly PFS.
I think the one thing is that this study, I believe, finishing or finish accrual, and belzutifan is not approved yet. So I think the control arm, there's no crossover. It's not going to get a HIF2 inhibitor. So what is left in a second, third, maybe everolimus? No, because the other, maybe not. So I think that is one reason why I think it's positive for OS.
So let's just end up with where we think this ends, because there's a frontline randomized trial, which is the frontline triplet study, and there's also an adjuvant trial of belzutifan or pembrolizumab plus or minus belzutifan. So these 3 trials, an adjuvant trial, a frontline trial, and a pre-treated trial. Do we think that belzutifan ends up in the adjuvant setting, the frontline setting, or early refractory disease, all in combination with therapy? Which is the most likely? Tian, should we start with you?
I like it in the refractory for people who we think are indolent, androgenically driven disease, and it's well tolerated.
So you like it actually as a monotherapy?
I like it if in those circumstances for that patient population. I think for all comers, I'm excited to see what the frontline trial will show, because I do think the combination data is quite striking.
Brian, of those 3 settings, which do you think it ends up in?
Frontline triplet.
Frontline triplet.
I actually think that it could work in adjuvant too. I'd go a step beyond that.
Tony?
I think the adjuvant study going to be the biggest next thing after 564.
The last slide I wanted to talk about, we talked about this in the Euromigos Cup a little while ago, is tivozanib and belzutifan look similar to one another from an activity perspective as a monotherapy. Do you think that belzutifan is a better partner, an easier combination drug than tivozanib? And do you think that the strategy of combining and putting it early in the disease ultimately is the right strategy? Brian, do you want to take that question?
I just said that, what struck me when I go back to this, when I put this slide together was how similar the data was. I didn't realize that, obviously until I put on the same slide, I was a different comparator arm, et cetera. But I think maybe to Tian's point, obviously it's good to have options, and there's probably some patients suitable for one versus suitable for the other, and maybe we'll figure that out and God willing, have a biomarker. But I thought the data were really broadly similar on face value.
And it's quite interesting too. What if you were to sort of normalize against some of these differences? What if you, sort of eliminated that 12% of folks that got belzutifan second line, for instance? What if you really honed in on the subpopulation of patients, in the TiVo3 trial that had gotten prior O? I think the data looks even more similar at that point. And that would be my projection.
Tony, last word.
I would like 2 things added to this slide.
I agree.
Quality of life, if there, I don't remember
Doesn't
if there is
exist for TiVo3.
TiVo3 quality, I don't think so. And second, the cost. I don't know how much belzutifan gonna cost. At least maybe not
Is there a
the
discount on
US.
TiVo back of the room? Are we?
Yeah, how much the cost is.
So let's
Well, and then in that same time to response, is that on here? Time to response. That's
Oh, yeah,
very
that would
important.
be
That,
Critical on my slide.
1 minute.
yeah.
Okay, so
Yeah.
what we're going
Good
to do,
first draft.
we're going to wrap this up. Mike Atkins has arrived. Mike just won a Lifetime Achievement Award. Wait. And he's going to come in, and we're all going to chat when he arrives. Okay? And what I thought, so it's a 60 Lifetime Achievement Award. That's a big deal. But I'm going to try and orchestrate. This can be a disaster. Do we need to change the panel round? Because then we can come in and join the last panel. So do we want to... Is that okay? So before we go, we ought to thank the people... Oh, okay, we're going to stay. Okay, let's bring him in. Let's bring
when
him
he
in.
come, could we like all run at him and start?
No, let's not. Yeah, we could do that. That would be great.
Let's go.
Just stand up and clap.
Yeah.
Mike, congratulations on your Lifetime Achievement Award. That's amazing.
Yes. Tom's used to standing ovations. Thoughts.
Congratulations, Mike.
Thank you.
Yeah. And thanks for
I wasn't
coming.
sure what all this was about. Made it here, or that you've been making fun of us for days,
No, it's about
now
your...
you get to do
It
it
was
in person.
Tom.
David mostly.
It's about your 60 Lifetime
Oh my
Achievement Award.
gosh.
Should we rotate the panel round? And
Let's do it.
Let's do it.
You're staying. Yeah.